In 1774, Joseph Priestley published his discovery of the substance that Antoine Lavoisier subsequently called oxygen. In the same report, Priestley recognized the double-edged nature of oxygen therapy, stating that it might be peculiarly salutary to the lungs in certain morbid cases, but it might not be so proper for us in the usual healthy state of the body. Good afternoon. It is an honor to be invited to speak in this year's mid-year virtual convention. My lecture for today is entitled Perioperative Oxygenation, Too Much, Too Little, Just Right. These are my objectives for this lecture. I have nothing to disclose. So, oxygen use has been a pillar of perioperative care for a very long time now. Patients are given oxygen for different reasons. Patients with pulmonary disease experience a mismatch of ventilation and perfusion. For example, is in tuberculosis, where in areas of diseased lung tissue decreases the ventilatory capacity of the lung. Due to this, the lungs experience shunting of blood towards the more ventilated areas. This is called hypoxic pulmonary vasoconstriction, the mechanism by which the body compensates to maintain VQ matching and oxygenation. Oxygen supplementation causes vasodilation in the pulmonary circulation, improving oxygenation. This also causes an added benefit of decreased workload of the right side of the heart. Pre-oxygenation has been a useful technique to increase oxygen saturations and reserves. Studies have shown pre-oxygenation prolongs safe apnea time, giving adequate oxygen reserve for patients during airway management. Hyperbaric medicine uses oxygen chambers to increase the partial pressure of oxygen in patients. Among the diseases that use hyperbaric medicine as treatment includes carbon monoxide poisoning, gas gangrene, and decompression sickness. Pain has been treated with oxygen since the 1900s. For example, pain of angina pectoris have been treated with oxygen, and it was eventually discovered that hypoxia of the myocardium was the culprit of the angina. Other ailments that use oxygen as pain treatment include fibromyalgia and complex regional pain syndrome. Of course, we cannot talk about oxygen without talking about the prevention of hypoxia. A nasal cannula or a face mask has been commonly used to improve oxygenation. Patients that need artificial ventilation due to a decreased arterial partial pressure of oxygen use a mechanical ventilator to improve oxygenation. Another way to increase oxygenation is via ECMO. Extracorporeal membrane oxygenation pumps and oxygenates a patient's blood outside the body, allowing the heart and lung to rest. Most of the studies in perioperative oxygen therapy dwell on infections, probably due to the success in the use of oxygen in hyperbaric medicine. In the 2009 proxy trial, a total of 1,400 patients were enrolled in the study. The objective was to assess whether 80% oxygen decreases the frequency of surgical site infection without affecting frequency of pulmonary complications in patients undergoing abdominal surgery. Patients were randomly given either 80% or 30% oxygen intraoperatively, as well as 2 hours after. The study concluded that the administration of 80% oxygen did not result in a difference in the risk of surgical site infection and pulmonary complications. In 2013, a systematic review and meta-analysis done by Hovagimian compared intraoperative high and normal FiO2 in adults undergoing surgery under general anesthesia. The study reported on surgical site infection, nausea or vomiting, or pulmonary complications. 22 trials were included in the analysis, which had a total of more than 7,000 patients. High FiO2 was defined as range between 80 to 100% and normal FiO2 as 30 to 40%. The study concluded that patients receiving prophylactic antibiotics and high FiO2 had a decreased risk of infection. In patients who received inhalational anesthetics but without prophylactic antiemetics, it was determined that high FiO2 has a weak effect on nausea and does not increase the risk for postoperative atelectasis. In another study in 2013, Munoz-Price rationalized that oxygen at the wound site may increase bactericidal activity of neutrophils through increased oxidative killing. Also, she said that high levels of oxygen was associated with enhanced antibiotic activity. She concluded that though wound healing have many factors in play, oxygen supplementation during the perioperative period would seem to decrease the incidence of surgical site infection, corroborating the study done by Hovagimian. However, in another study from the Cleveland Clinic done in 2018, Kurtz et al. Tested the hypothesis that supplemental oxygen, 80% versus 30%, reduced the incidence of 30-day surgical site infection, healing-related wound complications, and mortality. In the 39 months of the study, 5,749 surgeries were analyzed. Patients were well balanced between 80% and 30% groups. The composite outcome was 10.8% or 314 out of 2,896 for the 80% group and 11% or 314 out of 2,853 for the 30% group, with a relative risk of 0.99 and 0.85 respectively. Furthermore, the treatment effect did not depend on any of the following factors: type of surgery, age, as a physical classification, primary diagnosis, a BMI of more than 30, smoking status, and laparoscopic versus open surgery. The study concluded that supplemental oxygen had no effect on the primary outcome, a 30-day composite of SSI, healing-related wound complications, and mortality. They added that supplemental oxygen in an effort to prevent infection and healing-related complications should not be given. They further rationalized that oxidative killing varies over the full range from 0 to 150 millimeters mercury of oxygen and requires oxygen to be transformed to the bactericidal radical superoxide to be used in this manner. They suggested that 30 to 40% inspired oxygen is sufficient to support oxidative killing by neutrophils, and other factors matter more than inspired oxygen. Pre-oxygenation is an essential component of airway management. Pre-oxygenation prolongs the safe apnea time or duration of apnea without desaturation. This prevents hypoxemia, which leads to dysrhythmias, hemodynamic decompensation, hypoxic brain injury, and death. But the use of high FiO2 during pre-oxygenation has its own complications. Resorption atelectasis occurs due to the washout of nitrogen by oxygen in the lungs. Nitrogen helps by acting like a stent in the alveoli as nitrogen is poorly soluble in blood. During pre-oxygenation, nitrogen is replaced by oxygen, which is readily absorbed by the pulmonary circulation. This in turn makes the alveoli prone to collapse. Decreasing the FiO2 during pre-oxygenation prevents this incidence. At the PACU, patients are susceptible to hypoxemia because of multiple factors which may result in atelectasis, VQ mismatch, alveolar hypoventilation, and impaired upper airway patency. Prolonged hypoxemia may lead to serious consequences, including arrhythmias, myocardial ischemia, and cognitive dysfunction. Due to this, it has been common practice in the PACU to supplement oxygen to patients who were administered anesthesia. Supplemental post-operative oxygen may prevent hypoxemia after all, but the excess oxygen has been found to have deleterious effects on the respiratory and cardiovascular systems. The lungs may be the most vulnerable to its effects for obvious reasons. High fraction of inspired oxygen has been found to induce absorption atelectasis and impede minute ventilation in spontaneously breathing subjects. This also worsens VQ matching by countering hypoxic pulmonary vasoconstriction and shift the carbon dioxide dissociation curve to the right via the Haldane effect. Detection of hypoventilation may also be impaired by high FiO2. A high FiO2 also has been shown to decrease cardiac output and increase systemic vascular resistance in healthy individuals and patients with coronary artery disease. With these parameters worsen in patients with heart failure. In 2014, Kelly et al. Studied the perception of patients to oxygen therapy. Patients considered oxygen therapy as life-giving, and they relate to removal or denial of oxygen as a sign of impending death. Patients also believe that oxygen is routinely given for the relief of dyspnea. These were probable causes for patients to demand or resist removal of oxygen therapy during their hospital stays. For some, especially in the critically ill, oxygen is a marker of disease severity and legitimizes the sick role. Although the physiological benefit for hypoxic patients cannot be disputed, there appears to be a definite placebo effect on patients with normal oxygen saturations. Before we talk about the detrimental mechanisms of hyperoxia, we must first understand the effects of hypoxia. Most of the oxygen delivered to the cell is used by mitochondria as an electron acceptor. This allows ATP to be generated from the energy released during the oxidation of carbon in dietary sugars and fats. In the event of tissue hypoxia, cells initiate an adaptive program. This is mediated by the transcription factors hypoxia-inducible factor, or HIF. HIF is degraded by von Hippel-Lindau protein, which is then hydroxylated by propyl hydroxylases, or PHDs. As the intracellular PO2 falls, the activity of PHD is inhibited, preventing the hydroxylation and degradation of HIF. HIFs increase the expression of glycolytic genes and angiogenic factors. This includes vascular endothelial growth factor, or VGEF. This adaptive program promotes cellular survival and revascularization, but often comes at the cost of reducing the function of the cell. Prolonged expression of this transcriptional program may disrupt tissue architecture, an example of which is the HIF-mediated release of VGEF from hypoxic cells in the retina, implicated in both diabetic retinopathy and retinopathy of prematurity. Arterial hypoxia also causes physiologically important changes in the pulmonary vasculature. In the vascular beds of most cells, hypoxia-induced vasodilation increases blood flow to the hypoxic tissue. In contrast, the pulmonary vasculature constricts in response to hypoxia through HPV, diverting perfusion to areas with better ventilation, leading to improvements in VQ matching. In patients with pulmonary disease, regions of the lung can become hypoxic, causing a significant increase in pulmonary vascular resistance. In these cases, oxygen therapy may benefit by causing vasodilation of the pulmonary vasculature. This is because the pulmonary circulation is sensitive to changes in PO2. Thus, the use of oxygen to vasodilate the pulmonary circulation might require the administration of a higher FiO2 than that required to fully saturate hemoglobin. Hyperoxia leads to cellular injury through increased production of reactive oxygen intermediates or species, also known as ROI or ROS. Examples of which are superoxide anions, hydroxyl radicals, and hydrogen peroxide. As ROS increase, they react and impair the function of essential intracellular macromolecules. Superoxide anions are dismutated to hydrogen peroxide and water. Hydrogen peroxide can activate pathways to facilitate adaptation to oxidant stress. However, when present in excess, both the superoxide anion and hydrogen peroxide are highly reactive and are capable of oxidizing cellular proteins and lipids. These ROS signal a process at the plasma membrane in a forward loop, further increasing ROS production. These ROS also activate signaling pathways designed to defend the lung against oxidant stress. Oxidant-dependent activity induces a cell cycle arrest and activates a program in which the cell consumes its own organelles in an attempt to maintain survival during a metabolic stress event. Despite the attempts of the cell to survive, the continued production of ROS activates both apoptotic and necrotic pathways to cause epithelial cell death. Simultaneously, the high concentrations of oxygen prevents the inhibition of PHDs, which target HIFs for degradation. This results in loss of the vascular endothelial growth factor or VGEF. That eventually leads to the death of the alveolar endothelium. The progressive destruction of the cell endothelium will contribute to an escalation in permeabilization of the alveolar capillary membrane, with ensuing pulmonary edema. And when the mechanisms to clear the edema are overcome, this will result in hypoxemic respiratory failure and death. As of now, no guidelines have been set for the perioperative oxygen therapy. But in 2018, a set of guidelines was published discussing oxygen therapy in acutely ill medical patients. And the following are their recommendations. The first recommendation applies to acutely ill adult patients already receiving oxygen therapy. This includes critically ill surgical patients. Recommendation is for oxygen saturation to be maintained no higher than 96%, as mortality rates are shown to be lower with the conservative group compared to the liberal group. The incidence of hospital-acquired infection and length of hospitalization have no difference in both groups. Some practical issues being raised with this kind of oxygen therapy includes demand for nursing care is increased as the upper limits of oxygen saturations are lowered. Therapy may cause claustrophobia. Nasal or throat dryness may occur. Hoarseness or irritation can be experienced. The delivery system may hinder patients' freedom of movements such as eating, drinking, and communication. For recommendation 2, this applies to patients with acute stroke or acute myocardial infarction with oxygen saturations of 90 to 92% on ambient air. They recommended that these patients not be given oxygen therapy, as mortality rate is lesser in the no oxygen therapy group. The recommended level to start oxygen therapy should be a saturation of 90% or lower. The third recommendation applies to patients with acute stroke or myocardial infarction with a saturation of 92% or greater on ambient air. Strong evidence suggests that no oxygen therapy is beneficial in this patient population. Mortality rates in patients with acute stroke are noted to be lesser in the no oxygen therapy group. The ideal oxygen saturation to start oxygen therapy in this group is likely below 93%. Oxygen Reserve Index is a new technology that provides real-time, non-invasive, and continuous monitoring of patients' oxygenation status. Regular pulse oximeters are able to monitor PaO2 or arterial pressure of oxygen levels below 100 millimeters mercury, as reflected as SpO2 or pulse oxygen saturation. When PaO2 exceeds 100 millimeters mercury, SpO2 reaches 100% and cannot read beyond that. But as PaO2 continues to increase after 100 millimeters mercury, so that mixed venous oxygen saturation or SVO2. The increase in SVO2 changes the absorption of the incident light, thus changing the signals measured with the increase in PaO2. Unfortunately, this device also has its limits. When PaO2 reaches 200 millimeters mercury, SVO2 will reach its maximum saturation and plateau. In a pilot study in the University of Texas, Southwestern and Children's Medical Center, ORI was able to identify imminent changes 31.5 seconds before the occurrence of a noticeable drop in SpO2. In another study from the Fukushima Medical University School of Medicine, they also found that ORI was able to predict a hypoxic state approximately 30 seconds before the decline in SpO2. A study in Japan in 2018 found that ORI decreased earlier than SpO2 during one-lung ventilation. And in 2019, Spanish anesthesiologists stated that ORI predicts hypoxemia during OLV, or one-lung ventilation. With the growing concern of hyperoxia in the OR theater, as well as in the ICU, a non-invasive tool that can provide continuous, real-time data may help anesthesiologists in deciding which patients to give proper oxygen therapy. In a summary, oxygen continues to be a valuable tool in medicine. Its use in prolonging apnea time is vital in anesthesia. Its use in hyperbaric medicine continues to help patients who have gangrenous wounds, by controlling or even curing these debilitating ailments. Patients with pulmonary disease will always rely on oxygen to prevent hypoxemia either by nasal cannula, face mask, mechanical ventilator, or ECMO. High concentration oxygen does not affect the incidence of surgical infections. The use of high FiO2 during pre-oxygenation will prolong safe apnea time but may also cause resorptive atelectasis. The use of lower oxygen concentration may prevent atelectasis. Hypoxemia is a common problem in the PACU, and the use of high FiO2 oxygen therapy may have deleterious effects. Patient selection is important with oxygen therapy in the PACU. The use of high FiO2 causes a decrease in cardiac output and increased systemic vascular resistance. The respiratory effects include absorptive atelectasis, worsening VQ matching, and a rightward shift of the carbon dioxide dissociation curve. Target oxygen saturation is more than 95%. Oxygen therapy should stop after an oxygen saturation of 96% or above is achieved. In patients with an acute stroke or myocardial infarction with no oxygen saturations of 93% and above on ambient air, no oxygen intervention is needed. Oxygen Reserve Index is a very useful technology that provides real-time, non-invasive, and continuous monitoring of patients' oxygenation status. ORI may provide early warning before saturation start to decrease, and with a combination of pulse oximetry, may avoid excessive hyperoxia or unanticipated hypoxia. Thank you and have a good afternoon.